All right, let's get right into it. Welcome to today's Explainer, where we're basically taking a giant magnifying glass to a deeply entrenched habit in the medical and rehabilitation world. We're looking at a genuinely fascinating paper by Damian Keeter and his colleagues that completely challenges how we classify treatments in rehab. For decades now, we've been operating on this fundamental assumption about how to treat patients, neatly filing every single intervention into one of two boxes: active or passive. But as we're about to see, this categorization, it might actually be doing our patients a massive disservice.
So let me ask you something. Is passive treatment really a bad thing? Think about the modern rehab golden rule for a second. In a ton of clinics today, the prevailing mindset is that if a patient is sweating, moving, and physically exerting themselves, an active treatment, then it's inherently good. It's progressive. On the flip side, if they're lying on a table receiving a hot pack, electrical stimulation, or hands-on therapy, a so-called passive treatment, it's very often dismissed as outdated, inferior, or just plain bad. But does that binary way of thinking actually hold up to scientific scrutiny?
Well, it sets up a pretty stark conflict. On one hand, you have that rigid golden rule: active equals good. It's a neat, tidy heuristic, super easy to remember. But on the other hand, we have the messy, beautiful reality that Custer's paper brings to light, which is that clinical care is highly nuanced and fundamentally person-centered. The paper argues that this strict active versus passive delineation has some critical flaws. It turns out, treatment planning is way more complex than these rigid labels suggest, and relying on them might actually undermine the very principles of patient empowerment we're trying so hard to promote.
Which brings us to Section 1, the false rehab dichotomy.
And Section 2, defining the undefinable.
The source paper makes a really clear argument here. These binary classifications are poorly defined, widely misinterpreted, and honestly, they offer very limited clinical value. To really understand why this dichotomy falls flat, we have to look at the definitions themselves. What's actually fascinating and kind of funny is how wildly inconsistent the scientific community is about these words. Within rehab medicine, active describes direct physical participation, right? Like doing an exercise, while passive implies limited physical engagement from the patient, like getting an ultrasound. But step outside of rehab and the definitions flip entirely. In fields like psychology, pharmacology, and immunology, they use the exact same words, but the criteria are totally different. What one field calls passive, another considers a highly active biological or cognitive process. So right out of the gate, we're using universally recognized terms in incredibly isolated, confusing ways.
So the crucial point here is that we really need to rethink what it means for a patient to be engaged. The paper cites this fantastic definition from Higgins and colleagues. They define patient engagement not just as physical movement, but as the desire and capability to actively choose to participate in care. This shifts the goalposts in such a brilliant way. Engagement is cognitive, it's functional. If a patient is actively making choices about their recovery, collaborating with their provider, and committing to a plan, well, that is active participation, even if the treatment modality itself doesn't require them to break a single drop of sweat.
To really hammer this home, the authors use a thought experiment that is just too good not to share. Let's call it the calf spasm test. Imagine a patient gets a really painful calf muscle spasm. In scenario A, the patient identifies the spasm and actively decides to apply a hot pack to ease the pain so they can perform their exercises later. According to strict rehab definitions, the hot pack is passive. Now, in scenario B, the patient leans against a wall, allowing the external force of gravity to stretch the muscle. This is widely considered an active stretch. But wait a minute. Why is gravity doing the work considered active while a patient purposefully self-administering a hot pack to enable future exercise is labeled passive? It's completely arbitrary. And honestly, it shows exactly how silly these labels can get.
Let's look at Section 3, flaws in the binary. These arbitrary definitions cause real systemic confusion in the data, especially when you look at the research layer. Even top-tier medical researchers struggle to keep these categories straight. Case in point, a 2025 network meta-analysis by Bernacini and colleagues tried to classify treatments based on patient effort and movement, but even they couldn't escape the trap. Identical interventions carried out by the same authorship group were categorized differently across different studies. Get this. Combining electrical stimulation with exercise was deemed an active treatment, but combining manual therapy with the exact same exercise was somehow labeled passive. Think about that. If our absolute highest level of clinical research can't consistently fit real-world treatments into these prescriptive boxes, how on earth can we expect practicing clinicians to do it?
And here's the real kicker. The clinical data itself doesn't even support the active is always better rule.
Active treatments, when used in total isolation, have not consistently demonstrated superior outcomes compared to multimodal care. In fact, studies show that active strategies frequently perform equally to manual therapy or electrothermal modalities alone. And crucially, adding manual therapy or psychological interventions to an active treatment generally performs just as well, if not better. The narrative that isolated active exercise is the undisputed universally supreme gold standard, it just isn't backed up by the comprehensive evidence.
Which leads us to Section 4, the multimodal reality.
So, if the binary is flawed and the data doesn't support isolated active care, what is actually happening in clinics right now? Well, a recent retrospective analysis by Mayer et al. Delivers a massive dose of reality. 70% of cases in the real world are managed using multimodal therapies. That means a combination of active, passive, and manual interventions. That is a massive majority. Clinical practice already operates on a spectrum. Clinicians aren't limiting themselves to a single prescriptive box. They are intuitively mixing and matching tools to help the patient feel better and move better. The active-only argument is basically a ghost in the actual clinic.
And just to reinforce that point, check out this other huge statistic from Faroqi and colleagues in 2024. 66% of cases in their data were managed with multimodal care. The fact is, multimodal treatment has become the standard of care for many, many conditions. Limiting care to a single type of modality completely contradicts best practice. Real-world clinicians are already out there ignoring the binary because they know firsthand that combining approaches is what actually works for complex human beings.
Section 5, a person-centered framework.
So, if we toss out the outdated active versus passive heuristic, what do we replace it with? The authors propose a truly evidence-based, person-centered framework. This goes way beyond just looking at a referring diagnosis or a specific region of pain. It requires a biopsychosocial perspective. It means that, yes, while you absolutely must appreciate the evidence based on the average patient with a similar condition, you have to simultaneously factor in the unique, specific context of the actual person sitting right in front of you, their biology, their psychology, their social circumstances. You can't just hand them an exercise sheet and call it a day because a protocol says active is better.
The authors actually break this down into a highly actionable, 3-step treatment planning model. Let's walk through it real quick. Step 1. You start with the guidelines for similar patients. What does the baseline evidence say? Step 2. You assess individual patient factors. How does this specific person differ from the average patient in the studies? And Step 3. Shared decision-making. You actively invite the patient to share in the decisions affecting their care. This isn't just compromising between two opinions, it's exploring the facilitators and barriers to different treatment options together. This right here is what true clinical reasoning looks like.
Now, what exactly are those individual factors in Step 2? They include things like personal beliefs, patient expectations, the balance of risk versus benefit, self-efficacy, and motivation. This is absolutely vital. A clinician might want to initiate a purely active exercise program, but if the patient has really low self-efficacy, poor social support, and zero motivation, pushing that active strategy might actually backfire. The barriers to behavior change might completely outweigh the benefits. In those specific cases, utilizing a so-called passive intervention that aligns with what the patient expects might be exactly what is needed to build trust, reduce their pain, and ultimately facilitate that active movement down the line.
Which leads us to our final, essential takeaway for today's explainer. When we finally strip away the arbitrary labels of active and passive, when we stop forcing complex treatments into two restrictive little boxes, we are left with a fundamental question that every single practitioner needs to ask themselves. Are we treating a protocol or the person in front of us? If our goal is truly to empower patients and maximize outcomes, it's time to abandon the false heuristic, embrace the gray area of multimodal care, and put the unique individual back at the center of the clinical puzzle. Thanks so much for joining me on this one, and I'll leave you to ponder that question.